All right, so diabetes mellitus or diabetes mellitus. All right, so we talk about there's such thing as diabetes insipidus, which we'll talk about Med-Surg 3. We're talking about diabetes type 1 and diabetes type 2, or DM1 and DM2. There's such thing as gestational diabetes. There's such thing as diabetes 2.5 and 1.5. We're just talking about 1 and 2. All right. So diabetes overview. So what is diabetes due to? Is due to excess glucose. Why is the glucose elevated? Well, that's why it's either type 1 or type 2. We'll get to that reason, right? But essentially, whether you have type 1 or type 2 diabetes, your glucose is high, okay? And it spills in the urine. Your urine can only pull back so much glucose per minute, right? It's working and pulling glucose, and whatever it cannot pull and put back in the bloodstream is going to spill into the urine, right? And that's called glucose in the urine, or if you're fancy, glucosuria, right, or glycosuria. So that's glucose in the urine. It spills in the urine, and when glucose spills in the urine, or it's in the tubules before it hits the toilet, what's it going to do? It's last-ditch effort. It's going to pull onto water, right? So wherever sodium goes, water goes. Wherever glucose goes, water goes. So you get pee. You get pee, yes, in the toilet. You get glucose in the pee, and what else do you get in the pee? You get extra water, right? So you get glucosuria and you get polyuria. You get a lot of pee, right? So those are already some of our symptoms of too much glucose, right? So this was first diagnosed like in 1500 BC. It's one of the first medical diagnoses out there, developed by like an Egyptian physician, and he diagnosed it and called it and said, your urine tastes sweet. It's like, why taste my urine? So anyways, they were to diagnose it all the way back then. It was extremely rare. But as we'll find out, we have a lot of people in America even that are of a bigger shape, right? They have a bigger waistline. They have obesity. Obesity was, only the kings were obese back then. But now it's much more popular nowadays. It's the leading cause of death in most developed countries. Why do developed countries have it? Because they're more obese, because they have more access to McDonald's and calories, right? We bring in calories? No. All right, so anyways, it's a 7th leading cause of death in the U.S. Every 23 seconds, someone who's is diabetic is diagnosed. It's very underdiagnosed because people don't seek out medical care, right? And that's another whole issue with American healthcare, but it affects everybody worldwide. Obesity is the #1 reason why diabetes is on the rise, right? So younger populations are getting bigger and bigger and bigger, and therefore it's getting diagnosed earlier and earlier and earlier with type 2 diabetes. As we'll find out the reason for type 2 diabetes, it would make sense why that happens. Type 1 diabetes is usually an autoimmune process where you're not able to produce insulin anymore, and we'll talk about those, the reasons for those, okay? So risk factors for diabetes, specifically type 2 diabetes. Why do people get type 2 diabetes? Well, we mentioned obesity, but something you can't modify is who your family is, right? So you can't modify if you're gonna have a 9-pound baby or not. All right, that's not your fault. But your age, you also can't modify as you get older and older and older. If you're at risk for diabetes, you can develop diabetes, right? And then again, family history. If your brother or father or first-degree relative has it, you're at a huge risk. There's like 5 to 10x risk of getting diabetes. Right? And then we have modifiable things, right? Despite your family history and your age, these things you can modify, right? What can you modify? You can modify if you have prediabetes. If you seek out healthcare, they'll tell you if you have prediabetes. They can measure your A1C, your hemoglobin A1C, which we'll talk about, and that tells you if you have prediabetes, or it tells you have diabetes, right? Either way, that's a risk factor. And then we can lump these together into what's called metabolic syndrome, which is a group of lab tests, a group of symptoms that classifies obese individuals and puts those obese individuals at a high risk of developing not only diabetes, but atherosclerosis and cardiac disease and all kinds of things. So we'll touch base on this again when we talk about cardiac. I think it's next week, right? We'll talk about cardiac and lipids and all those other things, right? So that's all, there's overlap here. But the important part is that obesity is usually the linchpin that really triggers a lot of these chronic diseases. It triggers CHF, triggers ASCVD, which is, what is ASCVD? That's the new term the last 20 years for atherosclerosis. Atherosclerosis is out. Now it's called atherosclerotic cardiovascular disease, ASCVD. All right, so ASCVD is an important thing that we'll talk about next week, but diabetes is one huge risk factor for that. So we have to kind of mention what came first, right? And then, of course, the ASCVD can lead to diabetes. So it's all intertwined, right? So usually the thing that we can do to fix this is eliminate the obesity, okay? When you're obese, you have dyslipidemia, which means your lipids are abnormal. Your BMI being greater than 26 is a big risk factor for getting diabetes, and also, like we said, ASCVD. And specifically, apple shape is worse than pear shape. Pear shape means you got a booty. Apple shape means you got a waistband, right? So waistband, especially in men, more than 40 inches. Females, greater than 35 inches. But those things, if it's bigger than 40 inches, your waistband, not your booty, that's a sign of one of the triggers that could put you at risk for diabetes and ASCVD, right? And then hypertension. Hypertension is, diabetes causes hypertension, and ASCVD causes hypertension, so it's all interrelated. And we'll talk a lot more for cardiac when we talk about how to fix hypertension, how to fix someone's lipids, and how to fix those things, right? So you can see one of the major things we're going to recommend are diet and exercise. Right? We make a little triangle of things that are integral to managing diabetes is diet, exercise, and then medications are another thing they have to be compliant with. Okay, so it's very popular and it's very common in those who are sedentary, obese, and have these risk factors here. All right, so type 1 diabetes. So there's two types. Type 1 is about 5% of the population. That's where it's something you developed. It wasn't your fault, right? It was an autoimmune response. It was something attacked your pancreas. And what's in your pancreas are the islet of Langerhans. And what's in the islet of Langerhans is your alpha cells, beta cells, and gamma cells. Which one is it? What does insulin come from? The beta cells, right? Your beta cells are where you produce insulin. That's the only hormone we have ever to lower our sugar. Otherwise, our sugar's high, okay? If you don't have insulin, sugar's high, right? That's the only thing we have to lower our sugar, okay? It keeps your sugar under 200. That's the job of insulin, all right? If there's too much insulin, then we're gonna fire off some other hormones to start raising the blood sugar, okay? And some of those other hormones will inhibit insulin also. And one of those hormones being off the screen there, but alpha cells in the pancreas produce glucagon, all right? So glucagon is a hormone that raises blood sugar. So these two are going back and forth, keeping your blood sugar normal. Why do we need blood sugar? We talk about in ABGs, right? Sugar is what's needed for energy, ATP, right? We need to be able to get energy somehow. And when our cells do not get the sugar into them, they're going to start freaking out, right? They're going to start flipping out, starting getting some respiratory alkalosis. I can't, where's my sugar at, right? And what are they going to do? They're going to send signals off. I don't get any sugar, right? And then and then what's going to happen? Those signals are starvation signals, right? So you get hungry. So you have polyphagia. You're extremely hungry because your cells are starved of glucose. They're not really starved. It's just, or yes, they are, because here you have no insulin to put the sugar into the cell. The whole goal of insulin is it brings the sugar transporters close to the cell membrane so that glucose can go from the bloodstream into the cell. No insulin, that doesn't happen. Sugar does not go down. Sugar does not go into the cells, right? So in type 1 diabetes, the insulin producing cells, the beta cells, die. They are attacked, right? It's an autoimmune process. We have a damage to the beta cells, right? So autoimmune situation, we have antibodies that attack it, right? So usually they have something else autoimmune going on. They have vitiligo, they have Hashimoto's, lupus, etc. We talk about these in Med-Surg too. But these things put you at risk for type 1 diabetes, all right? The other important thing that causes type 1 diabetes and causes destruction of the beta cells is our environmental triggers. So what's environmental? A good barbecue with nitrosamines, all right? So those things will cause damage to the beta cells and cause them to die, right? And then so cured meats, bacon, beer. So don't feed your kids beer. This usually happens in younger individuals, right, when they're still forming their immune system and such. And then drugs and toxins can trigger someone to develop type 1 diabetes, as the drugs and toxins will damage the beta cells directly. Certain viruses will do it, and stressors, such as puberty can put them into type 1 diabetes, surgery, or someone who's chronically in and out of the hospital as a younger individual. So type 1 diabetes is someone that is young. It's really hard to develop it at an older age. It can be diagnosed all the way up to like age 30, 35, but it's very, very common in young kids, right? And it's a destruction of the beta cells, okay? So we have all these environmental triggers up here, all right, that are going to cause destruction of the beta cells directly, and or we have an autoimmune attack on the beta cells. We're forming antibodies that attach and attack those beta cells. Those antibodies might attack the virus, right? They're going to attack the virus, but the virus looks so similar to our beta cells, both of them die, right? So then we have a type 1 diabetes on our hands, right? And we'll talk about the symptoms of type 1 diabetes. So diabetes in general. So we have what's a normal glucose. Remember, we have insulin and glucagon. Those are to keep our sugar normal, right? Which one lowers the sugar? It'd be nice if glucagon made the glucose go gone, but the glucose does not go gone with glucagon, right? So glucagon makes the glucose go north, I guess. Actually, it's a good mnemonic. And it makes the glucose go north. It makes it go up, right? So insulin is our only hormone that we have to lower our glucose, right? It keeps the sugar under 200. If it makes a nosedive and the sugar keeps going down, 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 100, 80, 70, 60, now glucagon's gonna kick in and say, oh, that you had enough fun. Now it's my turn to start raising the sugar, okay? So glucagon is a hormone that comes from the pancreas that will raise the sugar. It will bring the sugar up above 80 at least, right? It's there. These guys work in concert, but since hyperglycemia is not as bad as hypoglycemia. In the hospital setting, hyperglycemia is horrible, but hypoglycemia causes life-threatening or life-altering permanent changes to a person, right? So those changes are, you remember, you have your medulla needs oxygen, it needs blood flow, and it needs blood glucose. So you need blood glucose to operate everything, so including your brain. If you don't get glucose to your brain, the cells die, you get cerebral edema, and it can be a comatose state, and it can lead to death. So we need to make sure we don't get what are called neuroglycopenia. What does penia mean? It means low, right? Neuro means neurosymptoms, glyco meaning glucose. So we get neurosymptoms when our glucose gets way too low. So that's the ultimate low, I guess you would say. The ultimate problem with hypoglycemia is permanent neurological damage, okay? So it's pretty important that we keep the glucose greater than 80, right? So we're not going to rely just on one hormone. We're not going to rely just on glucagon. We got 3 others to help out, right? So we have 4 hormones in our body to raise the sugar and 1 hormone to lower it, right? So why is this important? Because sometimes we take steroids outside of our normal steroids. Sometimes we have extra steroids being produced by our body, and those steroids are called glucocorticoids. Why are they called glucocorticoids? Because they affect the glucose, and they come from the corto. The corto of what? The adrenal glands. So the adrenal glands produce several different hormones, and one of them being cortisol. All right, so cortisol comes from the adrenal cortex there, okay, the middle layer. The adrenal cortex, adrenal gland, except remember, has like a nougat center, right? What's comes from the little nougat center, the adrenal medulla? What comes from there? Epinephrine and norepinephrine. So those two come from the medulla itself, and ironically, they also are going to raise blood sugar, right? Remember, low blood sugar is a trigger for SNS, and S is going to try to fix that, right? S is going to say, okay, I know how to fix that. Let's release norepi and epi, and we're going to go out and raise the sugar. Okay, so epinephrine and norepinephrine are important reason also to raise your sugar. Like when you're running away from a bear, you want to have the sugar for your muscles and cells to run, right? But back to cortisol. Cortisol comes from the, there's the bark of the adrenal gland, right? There's the medulla, and there's 3 layers around it. The first layer we don't care about, that's testosterone. The second layer is the glucocorticoids, and the last layer is the mineralocorticoids. It's just a fancy way of saying mineral, right? And what minerals does the mineralocorticoid affect? It squeezes out aldosterone, and aldosterone changes which minerals? Sodium and potassium, right? So that's the only job of the outer layer, is to release aldosterone in response to the RAS and SNS, which we'll talk about a lot more next week when we talk about blood pressure and such in the RAS system. All right, but either way, there's just kind of a preview of where it's coming from, right? So the mineralocorticoid layer releases aldosterone. Aldosterone is going to affects sodium and potassium levels, right? But the layer we're worried about is our cortisol. Cortisol comes as a glucocorticoid. It's a cortex hormone that's going to raise our glucose, right? So it's released during stress, immune response, and also an SNS response, ironically, right? So that's going to be a hormone that's going to raise blood sugar and make sure the blood sugar is elevated so that we can fight off a infection, for instance, right? So cortisol is released during an infection, and it's there to support the whole immune system, okay? It actually makes the immune system not get out of control. And we'll talk about that a lot more in Med-Surg too when we talk about sepsis. And there's inflammatory stuff and anti-inflammatory stuff. And cortisol is there to, calmate. It's okay, tranquilo, all right? Don't suck it out of hand. Okay? So then we have our third hormone to raise the blood sugar. Actually, our fourth, if we talk about glucagon, cortisol, epinephrine, and our fourth one being growth hormone. As a growing person, it makes you grow. As a human, or an adult, right? As an adult, the only job is to raise your sugar, right? When your sugar low, glucagon gets released. Glucagon, but growth hormone gets released, and it's going to raise our sugar. The whole purpose of this is to save the brain from dying, right? To save our cells from dying. We want to have the sugar available so that our cells don't starve and die officially, right? So you can see as the sugar starts getting lower and lower and lower, first glucagon gets released, and then we get adrenaline. Adrenaline is the same thing as catecholamine, is the same thing as norepinephrine and epinephrine, right? And then we have growth hormone released there as well. And then finally we get cortisol release. Cortisol is going to be the quarterback that's going to ultimately raise the sugar. And we'll show why it does that, right? And cortisol can be endogenous or exogenous, which means endogenous means we produced it ourselves. We were the ones making so much glucocorticoids. Or exogenous, we give people steroids, right? We give them prednisone, we give them methylprednisolone, we give them dexamethazones. These are all steroids we give a patient, and you have to say, well, shoot, they're at risk for what kind of glucose changes? Hyper or hypoglycemia? Hyperglycemia. And it can get to the point that the hyperglycemia causes type 2 diabetes, and that's not good. So we have to make sure we're monitoring those things, okay? So here at the bottom here, we got low sugar. If we have a low sugar, we're going to fire off all cylinders, cortisol, glucagon, epinephrine, and we're missing, what are we missing there? Growth hormone, which is to the left, right? So we've got all those guys are going to fire off, and they're going to raise the sugar. How do they raise the sugar? The elote? No, they're going to go out there and they're going to make sure that sugar gets made, right? They're going to bring the sugar out from all the storage places. They're going to break down stuff, and they're going to bring it to the basic molecules so we have sugar available to use for our cells, right? So we have glycogenolysis, lipolysis, and proteolysis. Only one of these hormones causes protein breakdown because those are valuable, right? We don't want to break down proteins when we're in a moment of stress, right? But cortisol is the only one that breaks down proteins. And on the other end, if our sugar is too high, insulin will get released, and it will try to inhibit those things to stop the sugar from getting too high. Okay? So again, insulin, how does insulin work? Insulin goes over here in the bloodstream. It attaches to the cell receptor, and it says, hey, it's time to absorb glucose. So it makes this little transporter go to the cell surface, and then now glucose can make its way into the cell, right? Without insulin, that transporter does not arrive, right? And then now glucose stays in the bloodstream. Okay? So those are an overview of our hormones that are going to affect our sugar. All right, so again, where does sugar come from? Is it magic, or how does it even get there? Well, first of all, you have to eat, right? So the reason you eat is to have sugar for later, all right? So on the right side there, on the top right in green, that's your fed state. That's where you are eating, right? In the first 0 to 4 hours after you eat, your stomach's digesting, it's absorbing the 3 macronutrients, right? So who remembers a nutrition class, right? So proteins, you have carbs, and you have fats, right? Those 3 things get absorbed and stored away for later, right? Some of us eat more fats than others, and those fats are going to get stored away as triglycerides, right? And then for a fatty day, or a rainy day, I guess. Which was that today? So anyways, we have all these things get stored away. Glucose gets stored in our liver and our muscles as glycogen, All right, so we have glycogen gets stored here for later. That's usually our first stop. If we raise our sugar, we're just going to break down the glycogen into glucose. Done, right? And that's when we are in a starvation state. So the glucose will immediately be available when we break down glycogen. Again, lipids are going to get stored away as triglycerides. And then our proteins are going to get either, they're going to be reutilized, they're going to be broken down and reutilized into amino acids if we need them, all right? To make more proteins. If we don't need them, they're going to get excreted, right? How do they get excreted? They get excreted as urea, right? Blood, urea, nitrogen. And when we talk about cirrhosis, next rotation, Med-Surg 2, that we're going to zoom in on that part right there because that process gets broken. And people with liver cirrhosis get elevated ammonia levels because that process cannot carry out, okay? When we talk about kidney failure, they have elevated BUNs, right? When they have excess protein intake, which is actually a myth, which we'll talk about. So anyways, we have, what else? So those are the three things you absorb and store away for later. And then when it's in a starvation state, we need to get that sugar out, right? And we have 4 hormones to do that, right? How do you get the sugar out? You either break down the glycogen. All 4 hormones break down glycogen, right? And then we have lipids, right? All 4 hormones break down lipids. And then we have proteins. Only 1 hormone breaks down proteins. And that results in all the symptoms of excessive steroid use. And when we talk about respiratory, like think of for exam 3 or the final exam, that's all those symptoms kind of make sense. So, oh, it's breaking down this, it's breaking down that. That's why you have this symptom and that symptom. Okay, but what we're going to focus on for diabetes is when you break down too many lipids, right? Too many lipids. The sugar is it's at the top of the food chain, and it gets to pick what it likes. Or it's like, hey, I got some amino acids for you to break down. No, I don't eat amino acids, right? Well, I got some lipids for you to break down. No, I don't eat glycerol or free fatty acids. So the liver goes, okay, let me, just like chops it up or spits in the bowl, and then it brings it back. I got ketones for you. Oh, I love ketones, thank you, because it only will eat glucose and ketones. That's all the liver, the only thing the brain will consume. So really, it's the brain's fault that we have diabetic ketoacidosis, right? So we form ketones that the brain will only consume. Everything else, all the cells will eat whatever. They'll eat amino acids, they'll eat lipid products, they'll eat all these things, all right? So that's the idea, all right? So glycogen is broken down into glucose when we need it, and we have those 4 hormones to do it. We got adipose, right, America. That's the one where we're gonna have plenty of that to break down, and we are then, of course, more at risk for decaying. And we got proteins get break down into amino acids. All these things are energy for when we're in our starvation state, right? So when we need energy, we use these different processes here. And the one that's a problem is the ketones that get formed, okay? So this summarizes what we just talked about, right? So we got hypoglycemic hormones here, right? That lower sugar, and all these other ones raise it, okay? So all these other hormones will raise it. Talk about where they come from. We know a lot about norepi and epi. That comes from the SNS response, right? And growth hormone is really after you're adult, all it does is raise the sugar. Cortisol has some untoward side effects if you have too much of it, okay? So that's the idea behind these. And also notice that cortisol has a kind of circadian rhythm to it as well. Either way, that's the underlying reason why your sugar goes up. All right, so pathophys of diabetes. All right, so we have which diabetes? This is type 2 diabetes. So we talked about type 1 diabetes was due to what? Was due to destruction of the beta cells. Literally, there's no insulin being made, okay? In type 2 diabetes, insulin is being made up to a point until it gets exhausted. But that's usually advanced diabetes, type 2. But in the initial stages, what you're having is resistance to insulin. There's plenty of insulin circulating in the bloodstream, but your cells are not responding to it, okay? So we have insulin resistance. So insulin resistant, how is that happening? All right. So insulin resistance is due to lifestyle. So obesity, overeating, etc. All these things are going to increase abdominal fats. It's like, so what? So they're a little bit big boned, big deal, right? But the problem is that those lipids also produce what are called adipokines. Adipokines are inflammatory mediators. They're literally inflammation in a bottle or in a adipose tissue. And those adipokines, those little chemicals that get released with excess obesity, those chemicals go throughout the whole body and cause havoc. They cause you to be in an inflammatory state the whole time. so inflammatory that they cause your cells to not respond to insulin. Thus, you get type 2 diabetes. The other thing they stop is they damage the endothelial layer of your vasculature, cause you to have ASCVD. It's a whole downward spiral whenever you have obesity. Okay, so adipose tissues are interrupting this function. Remember, our insulin will come to this little cell right here. It will tell the little glucose transporter, the GLUT4, to come up to the surface to absorb glucose. But the adipokines, those little inflammatory adipose chemicals, are going to stop that from happening. So it's not going to work. Okay, so what happens now? Your cells are starving. Like, where's my sugar at? I'm getting no sugar. So the symptom the patient has is starving. They're hungry, right? They are very hungry, or mini hungry, or polyphagic, right? So they have polyphagia as a symptom when you have type 2 diabetes, and type 1 for that matter. Okay, so those free fatty acids, so we're going to start breaking down lipids, and we're going to start breaking down other things. We're going to release more hormones. They're saying, I'm not getting any sugar. So then now you send out all the cavalcade to raise the sugar. And now what do you have? You have hyperglycemia, right? Because your cells were not getting the sugar because the adipose was blocking it. And now the cells are saying, I'm not getting sugar. So the body says, I know how to fix that. Let's raise the sugar, right? But insulin cannot function because of the adipose tissue, right? Also, the adipose tissue is hogging it all. They're the ones that are actually responding to the insulin and getting bigger and bigger and bigger. So it's almost, it's catch-22. They're starving the body of all the insulin. Insulin is being made, right? But it's not responding to the normal cells. The fat tissue is actually sending signals to other tissue so they can be greedy and store it for itself. Okay? And then as a result, we get hyperglycemic because the cells don't know what's going on. They're like, why am I not getting any kind of sugar? So let's raise the sugar. You raise the sugar up, and what happens then? The hyperglycemia, the high sugar, actually damages the beta cells. It causes glucotoxicity. It actually kind of destroys those beta cells. So do the free fatty acids and adipokines, for that matter. So now you have this whole inflammatory process, and you have the hyperglycemia, and it's all damaging further the beta cells, and then the beta cells get exhausted. And now you've gone from type 2 to type 1 diabetes, essentially, right? The insulin resistance, like why is the cell is not absorbing the glucose? Why it's right there, the glucose is right there in the bloodstream. Why can't you just take it and put it into the body? Is because of those free fatty acids and adipokines, those inflammatory mediators from the fat tissue, is blocking it.
Okay, so that's basically what insulin resistance is.
Resistance means it's resisting the insulin. The glucose is here. Why aren't, and he's like, where's my glucose at? I'm not getting glucose. So the body says, well, let's increase the sugar. Let's increase it. And this guy's like perfectly happy because he works, right? But all the other cells are not getting it. So you get hyperglycemic, and also you get more fat tissue, and it's going to lead to a downward spiral of events, right? So you have this free fatty acids and this adipose, which is causing all the problems. And that's in America. We get a lot of fatty tissue, so it's going to cause, that's why it's on the rise, right? So that's number one reason why you get type 2 diabetes. And number one reason why it's getting younger and younger and younger is because of all the McDonald's, all the fatty sources that are getting into our diet, and we get a little more pudgy, right? Also, there could be genetics. There's genetic reasons for obesity, so sometimes people can't help it. That's fine. But, and also, again, if you have a first-degree relative that had diabetes, you're likely to get diabetes as well, 5 to 10x risk. Aging itself, so if you did everything right, but you had a high risk factors, like genetic reasons, then age in itself, the beta cells can die with age. And then meds, like you mentioned, glucocorticoids, such as what hormone? That is cortisol, right? Someone that's on steroid therapy, someone like with lupus, someone with advanced COPD, advanced asthma, might be on steroids. One of the side effects is hyperglycemia. Hyperglycemia is toxic to the beta cells, and then now you're going to get type 2 diabetes. Okay? All right, eventually beta cells can't keep up, and now your beta cells get exhausted. So it's resistance to exhaustion, whereas type 1 diabetes was just destruction and insufficiency, right? So that's the idea behind type 2 diabetes. All right, so the symptoms of diabetes in general, I guess it's the symptoms of hyperglycemia. When your sugar is high, we already mentioned you get polyuria, right? Why do you get polyuria? Why do you pee so much when you have elevated glucose? Because where glucose goes, water follows, right? So you're peeing out all this glucose, and the water is following it, right? You can measure that urine and say it's super. You can taste it too and say it's sweet and be an Egyptian physician, or you can just do a little dipstick and say, hey, you got a lot of sugar here, right? Did you drink something like something super sweet, right? Or do you have diabetes, right? So we'll do some more tests to figure out if they have diabetes or not, right? We'll look at the last 3 months of glucose levels, right? So the kidneys can process about 180 grams of glucose per day. They're filtered about 180 liters per day, each kidney. That's a huge amount of glucose, or a huge amount of things that it's processing. And we have little transporters. They're called SGLT2 transporters. Why do I have to know the name? Because we have SGLT2 inhibitors, right? We have different medications out there. So that's the reason why I usually give you names of things, is because there's usually a medication or a lab test that's going to use that name, okay? So we have SGLT2 transporters. They're called sodium glucose-like transporters, number 2, because there's 3 other ones. But either way, they are found in the kidney, and they're responsible for taking glucose from the urinary tract, right? Sorry, from the nephron, and putting it from the nephron back into the bloodstream, right? To keep your glucose good, right? But they can only pull out so much, right? After a while, if glucose is super high, that glucose is going to spill into the urine. It spills in the urine, so does water, because water follows glucose, right? So you get polyuria. So that's one of our P's, right? We kind of mentioned polyphagia as well, right? Polyphagia was because the cells were starving on the previous slide, right? And type 1 or type 2 diabetes, glucose is not getting to the cells. Type 1 diabetes is because of what? Why was glucose not getting to the cells in type 1 diabetes? The beta cells were not releasing it, so there was they had a legit reason. There's no glucose here, right? And in type 2 diabetes, the glucose is plenty there. The insulin is plenty there. It's just the free fatty acids and the adipokines from the adipose are blocking the absorption, or the mechanism to absorb glucose, right? So polyuria. So we have increased serum concentration. We are now dehydrated. So we're super dehydrated, and there's many different ways to describe dehydration on labs. You can say the osmolarity is high, the osmolality is high, the specific gravity is high. All these things mean concentration. We are super concentrated in our serum because all the fluid went out into the toilet, right? And we have a mechanism at play that will detect this, right? So it says, hey, you're super dehydrated. What should you do? You should drink water, right? So that's the idea. Your body knows that it's always testing the waters and always saying, hey, it's very, very concentrated out here in the bloodstream. How do I know it's concentrated? Well, because I shrunk, right? So when these cells shrink right here, they're called osmoreceptors. They detect osmolarity, right? When they shrink, these cells right here, see this cell is big, nice and big and juicy. And then why did it shrink? Because all the water from the cell went into the bloodstream to try to dilute the bloodstream, right? Osmosis is the movement of water from where there's a lot of water to where there's little water, right? So it all shrinks, right? And when it shrinks, that's going to cause what to happen? We got dehydration. We get our friend ADH, anti-diuretic hormone. Do you want to diurese when you are dehydrated? You want to anti-diurese. You want to not diurese. You want to not pee out too much, right? So what does ADH do? It goes out and it says, stop peeing out water. Hold on to as much water as possible. So ADH goes to the distal tubule right here. It promotes the absorption of urea. Urea is usually a waste product, but it's osmotically active. So where urea goes, water goes. So where sodium goes, water goes. Where glucose goes, water goes. Where urea, water goes. Where ETOH or alcohol goes, water goes, right? And of course, albumin. Those are our big determinants of our concentration. So it goes over there and it pulls water back in. So the water's about to go into the toilet, and then here comes ADH for a nice warm hug. All right, not today. Right, come here, brother. All right, so when you're super dehydrated, how are you going to fix the dehydration? You're going to go to the V2, the vasopressin 2 receptors in the tubules, and you're going to reabsorb water, and that's going to fix the problem. In the meantime, it's going to tell you that you're thirsty. It's going to work and fix the kidneys, right, to fix the problem right now. But what if, how do you ultimately fix this problem? You got to drink water, right? So that's going to tell you that you're thirsty and you should drink water. And if you're extremely thirsty, that's called what? Polydipsia. I have extreme thirst. So extreme thirst, extreme urine, and extreme hunger. Okay, so that is the idea behind this, right? And again, we can measure the glucose in the urine. If you've got 2+ on your UA, that's a glucose in the serum of 500. And so it's a way to test what the sugar is it's kind of an association. If the sugar's super high in the urine, it's probably super high in the bloodstream. Okay, so that's what's going on with the 3 Ps and why you get the 3 Ps, right? So let's see here. This is over here in the bottom left is what happens when you have those osmoreceptors are going to shrink, right? The water will leave the osmoreceptors. It tells the hypothalamus that they're thirsty and you need to do something about it. So ADH gets released. And it's going to vasoconstrict to raise our blood pressure so we don't get hypotensive, but it's also going to tell us, it's also going to tell the kidneys to reabsorb as much water as possible. Okay, so symptoms of diabetes. We got the 3 Ps, right? So 3 Ps, we know why those happen. And when you're dehydrated, you have a low circulating volume. ADH itself, vasopressin itself, stimulates the SNS, but also you're dehydrated. That's 2 SNSs. So when you have the SNS response, you get what? Tachycardic, tachypnic, and are you going to be diaphoretic? You would get diaphoresis with SNS response, but you have no water to give. So you have dehydration has SNS responses plus the dehydration stuff. So that means you have dry cracked mucous membranes, you have increased skin turgor, you have sunken fontanelles, you have all these things that are attached to dehydration, all right? So then we differ, so for symptoms for diabetes, we can differ them to type 1 and type 2 diabetics. Both of them have 3 Ps, both of them have hyperglycemia. But what about type 1 diabetes? They are thin in appearance. They're thin despite eating, right? They're not, the obesity is not the thing that's causing them to, develop diabetes, right? The type 1 diabetes. They are, they're going to be breaking down all kinds of things. They're breaking down lipids, they're breaking down fats, or lipids, proteins. They're breaking down all these things to raise the sugar because they don't have any, the cells don't have any sugar because there's no insulin, right? So they're starting to break down all these things to try to, to fix the problem, but they can't fix the problem because they don't have the insulin, right? So they're going to be thin despite eating, right? Compared to type 2 diabetic, they are thick despite eating, right? They are, the adipose itself is still interrupting the process. They're still hyperglycemic, but they don't lose weight because of it, okay? So type 1 diabetics are thin despite eating. They have the 3 Ps, and usually the most common symptoms that they present with are symptoms of the number 1 complication for type 1 diabetics, which is DKA, okay? Oftentimes when you study in books, they tell you that DKA is a symptom of type 1 diabetes. They're 2 different things. One's a complication, which is bad. You should be able to recognize it, but it's not. Type 1 diabetes itself is just the hyperglycemia piece, right? And the thin despite eating. That's usually a big clue that they are a type 1 diabetic, and usually younger in appearance, right? Usually 30 years or younger. That's a sign of a type 1 diabetic, right? So it's an insulin deficiency. There's no insulin being produced, right? Happens at an early age, childhood. It's only about 5 to 10% of diabetics. It's usually an autoimmune process, right? They're thin despite eating. They're usually not obese, right? Can you fix it with lifestyle changes? Just do some diet and exercise. Now we get your beta cells going again. No, you can't, right? That's not going to fix their dead beta cells or their dying beta cells, right? Genetics plays a huge role here. Again, the presentation, what are the symptoms? What are your signs and symptoms? You're going to have the 3 Ps for both type 1 and type 2, but type 1s, they're going to be thin despite eating, and they're going to have complications of DKA, usually at the same time. That's usually how they present. If someone presents in DKA, it's like, well, why do they have DKA? Well, it's new type 1 diabetes. That's usually a very common reason for DKA. All right, and we'll talk about DKA in more detail. All right, and then type 2 diabetes. Type 2 diabetes is where they have, they usually present, again, with the 3 Ps, but they usually present with complications, chronic complications of type 2 diabetes. And we'll talk about acute complications and chronic complications, right? There's a lot of complications that result from diabetes, All right. So blurry vision, they have retinopathy. Their retina is not working. They have cataracts. They have pins and needles and paresthesias. They have neuropathies. They have gastroparesis. They have all these chronic complications that develop. They can develop DK, but it's much more uncommon. All right. And HHS is another complication we'll talk about. We'll talk about DK and HHS. These are acute complications. You have acute ones that happen and end up in the hospital acutely, that are life-altering and very, very deadly. And then we have chronic complications that develop over time, takes 3 months, 6 months, years to develop. All right, and usually our type 2 diabetics present with those chronic complications. Okay, and then labs. So labs, we talked about glycosuria, that's glucose in the where? In the urine, and microalbuminuria. So microalbumin, you have little small pieces of protein, albumin, that's leaking into the urine. Because as we'll find out, in diabetics, that glomerular membrane that separates the bloodstream from the nephron can get destroyed. And that can tell you how bad someone's diabetes is. Diabetes is the #1 reason for chronic kidney disease as a complication. And then A1C. So we'll talk about A1C after the break with labs and such. All right, so quickly. Resistance is your type 2 or type 1 diabetic. That's a type 2 diabetic. And then deficiency is a type 1 diabetic, right?
All right, what do we got?
Just came in. Heart attack. 5'9", 300 pounds, 32 years old.
How the hell does that happen?
Can I get a, Could be developing diabetes. You have to make a change. Oh, yeah.
You're graduating! Watch TV. You wouldn't have to leave.
You can't do this.
Yes, can I get a...
Yeah, no, deep tip.
You have to make a change. Good job, Jim. You got an A+.
Are your fries, sweetie?
I still can't believe you did this child such
I know, but it's the only thing that'll make him stop.